All right, now we're going to talk about atrial rhythms. So atrial fibrillation is a pretty common rhythm that you'll see with our geriatric patients, and if you're on a cardiac floor or you're on a floor that has a lot of chronic illness. Okay, so atrial fibrillation, you really have to know. So when we talk about AFib, it's important to understand what's happening with AFib. Right, so we have our heart, okay, we have our SA and our AB. Now, when you have, so normally we have one leader, right? One person is in charge, the SA node, and it tells the AV node the messages, and then the AV node sends out the messages to the rest of the heart. Okay, that's easy. When we have AFib, we have a lot of different cells all wanting to be in charge, kind of like a revolution, okay? I like to think about the movie with Finding Nemo, and we have all the seagulls on the pier, and they're going, mine, mine, because they all want the fish, okay? So same thing in the heart, all these different cells, they all want to be in charge. So you have cells all over, and they're all sending out electrical impulses. Well, the AV node gets really overwhelmed. Oh my God, which impulse do I listen to? Okay, so only some of these impulses get through, and it's kind of randomly which one. So when we talk about AFib, we're talking about lots of different cells sending impulses, meaning all of those P waves that you see are all from different places, so they all look different. They're not uniform. Remember I said, if you've watched the video about analyzing a rhythm, that whenever an impulse is sent from a cell, it always looks the same. If a different cell sends out the impulse, then the shape and the way that picture looks, the way that wave looks, is different. Okay? So this would be AFib. Okay? Or atrial fibrillation. So it's a fibrillation. Okay? And it's important to note that the atria are fibrillating. They look like jello on a plate, and it's just like this. We don't get much cardiac output when the heart is going like this. Okay, and it's doing that because there's so much electrical stuff going on in there. All right? So this is kind of what's happening with AFib. When we talk about a flutter or atrial flutter, it's a similar situation in that it's atrial and something in the atrium is going a little haywire, but all the P's look the same. And that's because it's not a bunch of different cells, it's one cell sending out a lot of impulses. So think about the SA node has a lot on their plate, and so they drink a lot of energy drinks, and they're just like, they're really hyper, and they say, oh my gosh, I gotta get all this stuff done. And so they're sending out impulse. And the AV node can't keep up with that. So then you have a lot of P waves that all look the same because they're all coming from the same cell. And then more regular, but at a random rate, the AV node is picking up some of that electricity. Okay? So coming back to our analysis. So this one is fib. This one is flutter. Okay? They're both atrial problems. So let's analyze in our format here. Do we have a P for every QRS? No. We have a lot of P's. All of these are P's. Okay? They all look different in fibrillation. So we're just going to do fib right now. Okay? So we have, I'll just cover this one up for now. Okay? So we have in fibrillation, a lot of P waves with our QRSs. The rate in AFib, just AFib, is generally, actually it could be anything. So the rate varies. We're just going to say varies. You could have a slow AFib, which would be more of a bradycardia. You could have a normal, just regular AFib. or you could have AFib with RVR, AFib, RVR, AFib with rapid ventricular rate, and your rate is going to be greater than 100. Most people in RVR or rapid AFib are in like the 160s, 180s, and we have to treat, okay? I'll talk a little bit more about AFib here in a minute because it's really important. Is it regular? No. AFib is not a regular rhythm. So if you're measuring and all of your QRSs march out, you want to reconsider. It's probably not AFib. Nothing is always or never, but AFib is 99% of the time irregular. Okay? So, no. These are already different from all the other things that we've discussed. Wide or narrow? It should be narrow. Less than 0.12 for your QRSs. Okay? And then measure the PR, we cannot measure. You cannot measure because which PR do you use? Which P do you measure from? This one? This one? This one? Some of the P's you can't even see. Sometimes you can't discern what's a P and what's just a line. And then abnormal beats, not generally. All right, so that's AFib, how to analyze it. When we do a flutter, we can still have the rapid ventricular response problem. Okay. A flutter, the big difference is you have a sawtooth pattern. Sawtooth. See how all the P waves look the same? Okay, they kind of look like shark fins or shark teeth, or the teeth on a saw. That's why they call it sawtooth. Because they're all coming from the same cell, so they look the same. Okay? Is there a P for every QRS? No. What's the rate? It's usually a normal rate. Excuse me, 60. Is it regular? More often than not, it's regular. So whereas AFib 99% of the time is irregular, A flutter maybe 90% of the time is regular. It's much more regular than an AFib. Is it wide or narrow? It's narrow, less than 0.12 QRS. Can we measure the PR? Again, which P do we use? So no, we cannot measure. Abnormal beats, not usually. Okay, so AFib and A flutter are very important to understand. So when we talk about AFib, and get rid of flutter. AFib is a very common rhythm. Okay? Some very important things to understand. When your heart is pumping, okay, we have the atria and the ventricles, right? We receive blood from the body into the atria, and our heart fills. Our atria fill, our ventricles fill. When our atria fills and our ventricles are filling, we are feeding the coronary arteries and are getting a good stretch to get a good contraction, okay? Then the ventricles pump blood out to the body, right? That's the most important thing for cardiac output is the ventriculars. The ventricles squeeze the blood out to the body, okay? Right before the ventricles squeeze, the atria say, oh, I've got extra blood, here, have it. And they dump what they have into the ventricles, adding to that volume. And then the heart pumps the blood out to the body. We call this an atrial kick. It's 30% of our cardiac output. Okay, atrial kick. This is why it's so important that we have our atria contracting and working. So people that have AFib do not have an atrial kick. So they have their cardiac output reduced by 30%. So think about if you have someone who's pumping out 6 liters a minute of blood and they have AFib, you have to take 30% of that away. Now they're only pumping, you subtract 2 liters, they're only pumping 4 liters of blood. They're down 2 liters of blood that they would be using for perfusion. So we have problems with oxygenation, we can have problems with any of our organs because they may not be perfused as well as the rest of the body. So when we're talking about, from a nursing standpoint, what's so important about AFib? Why is it such a big problem? Well, because you're not getting the full cardiac output, so you're not getting full perfusion to all of your organs. The other thing that's super important is when your atria are fibrillating, like that jello on the plate, what's the blood doing? It's clotting. So now you're filling up your atria with clots. Now, if it's a brand new AFib, then you may not have had time to make clots. But if your blood is just like this and it's not moving very much, it's going to clot. What happens when now your atria all of a sudden start to pump? We shower you with clots. And so now you can have a stroke, you can have an MI, you can have a pulmonary embolus. So it's a real problem to have all of those clots in there. So two really, really important key things about AFib that you have to know as a nurse. One, cardiac output is reduced, and two, you are at high risk for clots. All right? So people that have AFib, your patients that have AFib, should be on an anticoagulant. And if they're not, then that's something you need to address with the physician from a patient advocacy standpoint. They should be on an anticoagulant, whether it's aspirin, Plavix, Xarelto, Coumadin. Coumadin is still our number one drug, okay? And when they're on Coumadin, remember we have to measure and keep track of their INR, and it should be 2 to 3 times normal, okay? And they can't eat things with vitamin K in it in their diet because then it will, that kind of is the antidote to Coumadin, that will reverse the effects of Coumadin. Coumadin is making your blood thinner, you're eating things with vitamin K, and that is now going to reverse the effects of the Coumadin. And now your patient is at risk for bleeding. Okay? So they're at risk for clots, they get started on their anticoagulant, and now they're at risk for bleeding. But this is what evidence shows us, that they're going to have a better outcome with anticoagulants than with potential clots. Okay? So when you have a patient on AFib, they have to be on an anticoagulant. If it's a new AFib, they might be on a heparin drip to get them started. Heparin drip. They might be on aspirin. When you're getting them on the Coumadin, you cannot stop the heparin until their INR is therapeutic. So it's they may be on Coumadin plus something else for a full week. They may be on Coumadin and Lovenox times 1 week until the Coumadin has brought the INR up. Now we can stop the Lovenox. Okay, so anticoagulation, very important with AFib. We also are watching for that RVR, okay, because if their heart starts to go really, really fast, it's going at 160, and you don't have an atrial kick, the cardiac output's going to suffer, your heart is going to struggle and work really hard and use up all of its oxygen, and your patient can crash. So if somebody goes into AFib with RVR, they're going to be put on a diltiazem drip, which is also called cardizem, until you get that rate under control. All right, they might be on cardizem PO as a routine med. Digoxin is the old drug that we used to use. They might be on that. All right, so as a nurse, you need to understand how to determine if someone is in atrial fibrillation. You want to determine if, look at their perfusion because their atrial kick is reduced. They need to be on an anticoagulant, perhaps a dysrhythmia drug like diltiazem or digoxin. Okay? You want to look at their diet. You want to talk about risks for bleeding, how to measure their pulse, okay, things like that. So very important things. If you have a patient with a brand new AFib, meaning they came in sinus rhythm, and all of a sudden you're watching on the monitor and they've gone into atrial fibrillation, then we can actually cardiovert the patient. Okay? We can cardiovert a new AFib. And that means you're going to hook up the defibrillation pads, but now you're going to put the machine on sync, meaning here they're doing their AFib thing. Okay, when you hit the sync button, you'll see these little symbols on the QRSs. That tells you the machine is recognizing what the patient's beat looks like, because you don't want to shock in the middle of a patient's beat. You want it to shock during one of these other periods, otherwise you could put them into a lethal rhythm, okay? But you can cardiovert and hopefully get them into a sinus rhythm, but that's only for a new AFib.